Thank you very much for that kind introduction. And although people quite often say it's an honour and privilege to be here, it is really an honour and privilege to talk to family audiences. And from my point of view, much more rewarding and meaningful sometimes than talking to my colleagues. So I apologise to them. So I'm going to talk about what these diseases are, why they happen, how we diagnose them, and how we might treat them, and along the way, some of the history. So what are they? Well, these diseases affect sheep and goats and scrapie, chronic wasting disease in cervid species, BSE in cattle, transmitted to cats in the form of feline spongiform encephalopathy, and on to certain exotic zoo animals. There's transmissible mink encephalopathy in mink, and Algerian dromedaries also have an illness. And of course, there are human forms of this illness, various forms of CJD, some rare genetic diseases, a disease called variable protease-sensitive prionopathy, and Kuru. So these are all very disparate diseases affecting very different kinds of creatures, including humans. So what brings them all together? Well, all of them are brain diseases. They're all progressive and currently fatal. They all have a similar neuropathology, which we call neurodegenerative, and they're all related to a specific protein abnormality. And all, or nearly all of them, are potentially transmissible. But fortunately, this transmissibility generally occurs only in certain very specific circumstances. So in the past, diseases were often named after people who described them. So CJD, named after Creutzfeldt and Jakob, first reported in the 1920s, remains the commonest human prion disease. Interestingly, although Jakob definitely did describe this disease, Creutzfeldt almost definitely did not, and his name is attached by a sort of historical accident, but it stuck. And then there's Gerstmann-Streusler-Schenker syndrome, in 1936, a genetic human prion disease. But then people moved on to descriptive names. So transmissible spongiform encephalopathy, brain disease, spongiform because of the spongy change, and transmissible because most of these diseases can be transmissible. And the first transmission of CJD was in 1968 to the chimpanzee. I've listed the authors here, and there are two in red. One is David Asher, who obviously was part of this first seminal publication and is present in the audience today. So he's worked his way through prion disease right up to the present moment. And there's Brian Matthews, whose portrait that you see here, because I came into CJD around about 1979 through him, and he is the father of clinical and epidemiological research into these diseases in the UK. Then in the 1980s, through the work of Stanley Prusner and others, the prion protein, its gene, and their role in these diseases was identified. And people started to use name reflecting the underlying disease mechanism, hence prion diseases. And proteins, just as an aside, are complex chemical structures. There's over 50,000 of them in a human body. They maintain the structure of the human body, and they have important functions in the human body. And their shape, the way they're folded as structures, is very important to their function. I've given some cartoon pictures here of a variety of proteins, just showing you the kind of complex shapes they can take. So in prion diseases, there's an abnormality in one of these specific proteins, a prion protein. And the normal prion protein is a normal protein. It's found in many animals, found in many tissues. And just to be clear, all of us are busy making and using prion protein in our brain and elsewhere in our body now. It's a normal protein. It clearly seems to be important, although its precise function is not clear. There are many functions that have been identified, but I think we don't know for sure what its critical role is in the body. In prion diseases, what happens is the normal prion protein, designated PRPC, changes its shape, its structure. And this is a very cartoon version here, and you can see it changes from being predominantly having lots of coils to having fewer coils and more sheets. And this abnormal final structure has been designated PRPSC, although I'll refer to this again a bit later. What we do know is once this happens, the abnormal form is able to encourage the normal form to change into abnormal form. So once you have the abnormal form, there's a kind of amplification process where it generates more and more of itself from the normal protein. And this abnormal folded protein has different physicochemical properties. So it's less easily broken down, it tends to accumulate, tends to aggregate, and then get deposited in tissues. And the arrow here shows a deposition of abnormal folded protein in the brain of somebody who died of one of these diseases. And this is really important to understand because it is basically the neuropathological diagnostic hallmark. In the end, the final arbiter as to whether a prion disease is a prion disease, as we currently understand it, is there aggregated abnormal prion protein deposited in tissue, seen under the microscope, as you can see on one side here, or if you extract the protein from the brain and run it on what's called a Western blot, as you see here, is it an abnormal form of the prion protein? And if that's so, then it is what we call a prion disease. However, these are diseases, and if we move away from proteins to people, it's an interesting question as to what makes human beings human, and I still find the answer is a very strange one, but there we are. Our brains and its millions of neurons and its billions of connections in electrical networks make us human. So prion diseases are illnesses, and they're illnesses because people develop symptoms, and they develop symptoms because neurons, brain cells, malfunction and die. And you get neuronal loss leading to these holes in the brain. So the question that really is critical to me is what causes neuronal dysfunction and loss. And I think it's fair to say our understanding of this is incomplete and uncertain. So the central disease question really is still not fully answered, despite everything we know about prion proteins. And in particular, the precise relationship between the deposition of abnormal aggregated protein in the tissue is not clear how that relates to neuronal loss. The precise relationship is not quite clear. And of course, I've sold you a simplified story, and I'm going to sell you now a slightly more complicated but still simplified story. The conversion from the normal form to the abnormal form doesn't go in one step. There are intermediate forms along the way. And indeed, it may be that these intermediate forms are really the most important forms in relation to disease causation and infection, and that the aggregated, deposited protein in tissue is not the key. So why do they happen? Well, here's the conversion process, and there are three broad reasons. The first is a genetic problem. You have an abnormal gene, so you have an abnormal protein, and it's more likely to change in shape. Second, acquired infection. Something enters the organism and causes the change. And thirdly, chance. And basically, we're making thousands and thousands or millions of protein molecules all the time, and there could be a mistake in production. And if there is a mistake in production, an abnormal prion protein may escape and then start to reproduce itself, or else we're doing this all the time, making mistakes, and there are cellular machineries which recognize these mistakes and deal with it, but there's a mistake, if you like, in the protein quality control network which allows it to escape. And that's what we think at the moment happens in sporadic CJD. So the main disease types, I'm not going to talk about all of them, but genetic prion disease due to inherited mutations. If your parent has the gene, you have a 50-50 chance of inheriting it. The clinical course is variable, and it depends in part, but not entirely, on the particular mutation. Iatrogenic CJD, a terrible accident where people have acquired disease by medical or surgical procedures. In the past, most cases due to growth hormone duramatrografts. Variant CJD, dietary contamination with BSE, mostly in the UK. No living cases in the world at this moment, as we know. Has occasionally been transmitted person to person by blood. And sporadic CJD, worldwide, the commonest human prion disease, mostly, but not entirely, middle-aged and elderly people, and mostly, but not entirely, with a rapid progression. Now I'm going to finish here with a complicated slide, but you've all got copies of it, so it's okay. This is a note about terminology. PRNP is the gene. It's a normal human gene, produces normal prion protein. PRNP star is a mutated gene, and it leads to an abnormal protein which causes genetic disease. Prion protein, in a neutral sense, is a protein labelled PRP. Prion protein PRC is the normal prion protein we all have. Prion protein mut is the mutated form that's resulting from a genetic mutation. Prion protein PRPSC is the abnormal prion protein in disease that aggregates and is deposited in tissues. PRP star is a form that people sometimes use to refer to the abnormal prion protein forms intermediate between PRPC and PRPSC. And prion protein res, and this is quite an important point, at least to me, if you get tissue and look for abnormal prion protein, there's normal prion protein in there. So you have to treat the tissue first to get rid of the normal prion protein, which degrades some of the abnormal prion protein. So what you see actually in slides where they say this is deposited prion protein is actually not PRPSC as such, but the resistant core of PRPSC, PRP-res. And then there's the prion. And as far as I'm concerned, the prion is the infectious particle, which on current theories consists entirely of or mostly of abnormal prion protein. The point about telling you all of this is that these terms are, in my view, conceptually quite distinct. And people sometimes use them almost interchangeably, which is confusing. And at best, it's imprecise. And I can tell you, to most neurologists, there's very little that bothers them more than imprecision. I'm getting treatment from Brian later, don't worry. And at worst, it causes confusion, and sometimes real confusion. So, how do we diagnose them? Well, first of all, you have to think of it, then you have to exclude other possibilities, then you turn to test to support your diagnostic hypothesis, and you have pathology. Well, I'm just going to briefly mention thinking of it, because you hear from people all the time, my clinician had never heard of CJD, they didn't know anything about it. Well, that's not surprising. It's very rare. Lots of people may have no knowledge or no experience. And you cannot expect a clinician to know about every disease. I've seen and diagnosed eventually lots of rare diseases, rarer than CJD, I can tell you, that I had no knowledge of when I first met it. You cannot expect a clinician to know everything. What you can expect is a competent clinician to recognise that there is a serious illness and know how to seek advice and information if they themselves don't have it. Exclude other possibilities. Well, a very important fact is that prion disease often presents non-specifically. The way it presents is the way many neurological diseases present, and there may be many other much more likely diagnoses, some of them even treatable when people first present. And many initial tests that are done are not done specifically for prion disease, like an MRI or lumbar puncture. They're done initially to exclude other possibilities rather than diagnose prion disease. So let's turn to the tests that do support the diagnosis. And I think that what I can say is that since the 1980s, there's been huge progress in this area. It's been one of the biggest developments of all. In the past, clinical diagnosis was based mostly on essentially non-specific tests that were not related to the basic prion protein mechanism, and they just happened, almost by chance, to be useful. So if people were going to see CJD cases like I did in 1980 or before, this is before prion protein, all you had to go on was the clinical features and the EEG. CT brain scan was available, but not MRI, and CT brain scan was good at excluding other diagnoses, but it produced no positive support for the diagnosis. The situation is now radically different. If you look at the essentially non-specific tests, these are not related to basic disease mechanisms. There's the EEG, brain MRI, and CSF 1433. You could extend it to one or two other things like tau, but I'm not going to. The relevant abnormalities that you see in the EEG, the brain MRI, and in the CSF can be seen in other diseases, and therefore their utility depends heavily on the clinical context and the clinician's interpretation of them. In addition, these tests may be negative. You may have a negative 1433, a negative MRI, and a negative EEG and still have prion disease. But despite these limitations, they've been very useful, and they continue to be so, particularly the MRI. And for a while, we have actually had 3 essentially specific tests. 1, detection of genetic mutation in genetic prion disease, which is pretty clear-cut. 2, neuropathological diagnosis, but this requires brain tissue, so it's at autopsy and therefore only after death, if you can get an autopsy, or by brain biopsy, which is not undertaken lightly. And 3, detection of PRPSC, the actual abnormal prion protein in tonsil biopsy, but this is relevant only for variant CJD. But in the last few years, there have been a number of non-invasive, essentially specific tests that are related to the basic disease mechanisms. And basically, we can detect PRPSC, which is what we need to do, but the standard methods of detection detect only high levels. And in CJD, other than variant CJD, high levels are found in the brain. Low levels can be found elsewhere, but they're low. But these detection methods would work if you could increase the low levels by amplifying them. And that's essentially what people did in very clever work. They hijacked this amplification that occurs in the disease to form tests. And in a very simple level, you have a sample with a small amount of PRPSC in it. You can't detect it. You add some form of PRPC, you do very clever things, and the PRPSC converts the normal PRPC into abnormal PRPSC, and then it's there in amounts you can detect. Very broadly and simply, there are 2 basic techniques that have been used, PMCA and RT-QuIC. There are refinements of these methods, and things will go further, and we may hear more about that at the meeting. But these are the 2 essential historical techniques. And they've been used on all sorts of tissues, spinal fluid, blood, urine, skin biopsy, nasal brushings. And I have to make some cautious notes. First of all, the 2 techniques tend to behave differently in different prion diseases for reasons that I don't understand. CSF sporadic CJD, RT-QuIC is very useful. It isn't in variant CJD. And in CSF variant CJD, PMCA is useful, and not necessarily the same for sporadic CJD. So you have to be quite careful to choose your technique. Secondly, there are a very large number of research developments, some of which you may come across at this meeting, but few have yet been properly evaluated in routine clinical settings, and all tests need to be before they go into use. One thing has been established, CSF RT-QuIC in sporadic CJD. It's now a standard test. In the UK, the sensitivity is over 95%. That means very few cases of sporadic CJD are negative. And so far, the specificity has been 100%, meaning we haven't seen a positive test in somebody without sporadic CJD. Now, different centres use slightly different techniques, so these are figures that I can give you for the UK only. And I should say one thing that's very important. No matter how technically good a test is, it needs to be used by an appropriate clinician at an appropriate time in an appropriate person. They are always and forever only part of the clinical process. Just as a footnote, you might say, okay, they've detected abnormal prion protein in blood or urine or skin. Is it a risk? Well, it's generally present at low levels. Detecting abnormal PRP is not necessarily detecting infectivity, as I implied earlier on in my discussion of terminology. Infection requires infectivity and an effective means of transmission, and touching somebody, for example, is not an effective means of transmission. And even if you can show infectivity in experiments from certain tissues, that's not the same as natural infection risk. There's no evidence of ordinary infection with human prion diseases, even with intimate personal contact. Just before we leave diagnosis, I'm just going to make a comment on the diagnostic maze. Somebody presents to a neurologist, they think there are 4 possibilities. They do some tests and one's eliminated, do some more tests, another is eliminated, and finally they get to one remaining final diagnosis. However, from the patient and family view, now, when you've got to the end, this looks blindingly obvious. Once you have a pathway through a maze, it's fairly obvious what the pathway was in retrospect. And of course, they say the clinical features which the person presented with was typical for CJD. But from the medical point of view, you don't know that beforehand. You have to find your way through the maze. And what's more, although the presentation was typical of sporadic CJD, for example, it was also typical of a number of other illnesses. And finally, you've got to remember that some of these possibilities along the way are potentially treatable. Now, frustratingly and agonizingly for all of you, this process takes time. But I would also say that in neurological disease, time is sometimes a necessary part of the diagnosis. The way the disease evolves over time may be very important in reaching the diagnosis. Pathology. Well, I'm not going to say any more about it than what I've already said. Pathology is the final definitive test, but actually a very confident clinical diagnosis is possible in many cases, and I think that we can diagnose things like sporadic CJD a lot more reliably in life than we can with quite a number of other neurological illnesses. So how might we treat them? Well, just as an historical note, from 1971 onwards, there were over 40 reports in the literature of attempted treatments involving some 15 drugs. Many drugs were chosen on the basis of limited evidence, many given to individuals or small numbers of patients on an ad hoc basis, most of them from a scientific point of view methodologically poor, very few properly constructed trials. If you look at the left-hand side here, there's a list of all the drugs that were used in these reports, which were found to be of no use. On the right, there are some drugs you may have heard of. Quinacrine was studied properly, as you heard yesterday, some of you, and this does not work. Flutapine, PPS, and doxycycline may have some minor benefit in certain specific situations, and some of them, like doxycycline, are still being studied. What have we learned from all of this? Well, hopefully to select drugs on a better evidence base, and I think we have, to consider how to evaluate the effects better, and I think probably we have, in other words, how to design assessment better, and also to try to develop useful biomarkers. Biomarkers are things that you can measure in the patient to see if the drug is actually affecting the underlying disease process, and you may hear something about development of biomarkers at the meeting. So let's just look at this theoretically. You've got a gene that produces a protein, the protein converts, and then you get neuronal loss. Well, if you start at the gene end, you might have a mutated gene giving you a mutated prion protein. And so you could try to interfere in some way with the mutated gene, and some people are interested in that kind of approach to genetic disease. You could deplete PRPC, because after all, PRPSC is being formed from PRPC, and so if you get rid of PRPC, there's nothing left to make more PRPSC. And in London, there is an antibody against PRPC, PRN100, which is, I understand, being currently used in 1 or 2 patients on a compassionate basis, but I don't have any knowledge of whether that is working or not. You could, of course, try to attack the aggregated, deposited prion protein, but for reasons I explained earlier on, that might not be the best thing to do. What's more promising in some ways is to attack the intermediate forms, so to find certain kind of small molecules that interfere with this transitional process on the basis that maybe these intermediate forms are more important in causing disease. And you could try to attack the process of neuronal loss itself, but as we don't fully understand that process, that's a slightly difficult matter. There are some things that we do understand, and probably the earliest changes that occur in these diseases occur in what are called the synapses, the connection between the nerve cells. And there is experimental evidence that some of these early changes are reversible. So perhaps we do have at least some optimism that if the disease process has started, we could perhaps interrupt it. But I have to at least give one note of caution. We have 2 situations here. One is treating a clinical illness, and the other is preventing an illness from happening. If you treat people who are already ill, the trouble with these diseases is they're often quite ill by the time they're diagnosed. And the question is, does late treatment, even if it were theoretically useful, does it work? And I must say that I'm a bit sceptical as to how far we're going to get with treating an illness like sporadic CJD once it's started. There's lots of Alzheimer's work being done, and in Alzheimer's disease, all sorts of semi-promising treatments have been evaluated in trials and have proved profoundly disappointing. And one explanation for this, it's not the only one, it happens to be one I favour, so that's why I'm mentioning it, is that it's too late. By the time you've got diagnosed Alzheimer's disease, the process may well have been going on for 10 or 20 years, and you need to treat it earlier. Prevention means treatment before you become ill, and that, of course, really centres on people who are genetic mutation carriers. And I think, without doubt, this is my personal view, the best way forward in treatment that we have at the moment is probably the prevention of illness in people who may become ill, for example, due to a genetic mutation. And there is a current trial in Italy at the moment giving doxycycline to people who are not ill, but who may become ill because of mutations, to see if this helps. So just as I finish, I should say that when I started out in this arena with Brian Matthews, it was basically CJD was part of a group of illnesses. We classed it with Alzheimer's disease, Parkinson's disease, and motor neuron disease. It was very common to have talks that grouped them all together for all sorts of reasons. And of course, then we left the fold and became almost independent of these other diseases, largely on the basis of transmissibility and infection. And I think recently we've started to return to the fold, or if you will forgive the pun, to the misfold, and we are now going back to our sort of sister diseases. And this is actually quite interesting at a number of levels, and I'm only going to mention two of them. One of them is, could we use things like RT-Quick, or these protein amplification things, on the other proteins in these other diseases? So, for example, in Parkinson's disease, the relevant protein is alpha-synuclein, and in our lab in Edinburgh, we have had some progress in developing a CSF RT-Quick test for alpha-synuclein. And so maybe we're going to get to the point of using some of these techniques from Prion disease to diagnose these other illnesses. But then there's also the question of whether these diseases could be transmissible. And that's an issue that I'm not going to go into. We left the fold because of CJD being transmissible and these other diseases not so, but now people are suggesting that maybe there is some form of transmissibility potential for these other diseases. But that, as they say, is another story, and I'm very happy not to enter it in this talk. So I'm going to finish there with an iconic view of our wonderful rail bridge in Edinburgh, and below it there's a message which you can interpret in any way you feel fit. Thank you.